Hello students, so now let's discuss about opioids, and in this section first we will discuss about what are the different opioid receptors present in our body, what are their effect. Then we will discuss drugs. In drugs we will discuss morphine, which will act on some mu opioid receptors. Then we will discuss a new class, mixed acting opioid. We all know that opioids are highly addictive drug, so we will see how to make a person de-addict. And lastly, we will discuss that opioids are used in the treatment of diarrhea as well. So first point is, sir, what are opioids? Remember, opioids are natural molecules and they are alkaloids. Alkaloid means basic drugs, and they are obtained from a plant, that is poppy plant. So exactly the scientific name of poppy plant is Papaver somniferum. Now we can see this poppy plant, and we can see there is a capsule of a poppy plant outside covering. So they are obtained from capsule of poppy plant. From this capsule of poppy plant, we obtain various natural opioids. Now some of these chemicals which are natural opioids, they have pain relieving property. So if they have a pain relieving property, we call them as analgesics. But some other chemicals, they are non-analgesic. They don't have any pain relieving property. So those natural alkaloids which have pain relieving property obtained from this plants are only two molecules. One is morphine, so it's a natural drug, and the brother of morphine, codeine. These two are natural opioids obtained from this plant. And among non-analgesic, we have various chemicals. First is papaverine, that is why the name Papaver somniferum. We have noscapine and thebaine. Out of this non-analgesic, papaverine, it is used in the treatment of peripheral vascular disease like Buerger's disease, etc. Why? Because it's a phosphodiesterase inhibitor, and phosphodiesterase enzyme produce vasodilation that will improve blood supply to a peripheral organ. While noscapine acts on a brain, and it is used as a cough suppressant, which we are going to discuss shortly. Thebaine does not have any specific use. Now in this section, we will be mainly focusing on analgesic drugs like morphine and codeine, and these two are natural drugs. And an important point is, natural opioids, they are also known as opiates. While we will be discussing certain synthetic drug as well, they will not be called as opiates. So one question is, does our body has opioid receptors? The answer is yes. So in our body, we have mainly three opioid receptors. First is mu opioid receptor. The symbol is written. Second is kappa receptor, and third is delta receptors. So these are the three main opioid receptors in our body. And remember, all opioid receptors are GI type of GPCR, G protein coupled receptor. But recently, we identified two more new opioid receptors. So two new opioid receptors which were identified in our body are nociceptin receptor and zeta receptor. Now these two receptors, remember, don't have any significance. They are not asked in exam, just for the knowledge we have discussed. Now we have to mainly focus on mu, kappa and delta opioid receptor. So one question arises in our mind, does our body endogenously also produce opioids? The answer is yes. So inside our body, again, remember, endogenous opioids are produced. And the endogenous opioid that is produced in the body that will act on mu receptor is endomorphin. or we can write endorphin. So these are opioids produced inside the body. Endo means inside, morphine-like molecule. The molecule that is produced in our body that acts on kappa receptor is dynorphin. So endomorphin act on mu receptor, dynorphin act on kappa receptor, while enkephalins, they act on delta receptor, and enkephalins are also endogenous opioid. Now, if we stimulate mu, kappa and delta receptor, what changes or effect will be produced in our body? So, let's first focus mainly on mu receptor. What is the function of mu receptor? We can remember with the help of a mnemonic, sacrum, no gap. Sacrum, no gap. So, stimulation of mu opioid receptor, it leads to S for sedation. Second point, they produce analgesic effect. Analgesic means they have pain relieving property. Then in GIT, remember they produce constipation. That is why we will discuss opioids are given in the treatment of diarrhea. And on brain, they suppress cough centers. So they suppress cough. That is why opioids are also given in cough syrup. Now, what is the cause of death? Due to opioid or morphine poisoning, the cause of death is respiratory depression. Now, why they are highly addictive drug? What is the cause of addiction? They produce intense feeling of happiness, which is known as euphoria. Because of this euphoric feeling, they are highly addictive drug. Now, inside the eyes, opioid receptor like mu receptor, they produce meiosis. Can we call this meiosis as pinpoint pupil, which will be a symptom of opioid poisoning we are going to discuss. Now, they produce nausea and vomiting. So, when a person takes opioid, it leads to nausea and vomiting because they stimulate CTZ area of the brain, that is chemoreceptor trigger zone, which is the vomiting center of the brain. Now, in GIT, remember they produce spasm of sphincters. Spasm of sphincters. And remember, when sphincters, which are circular muscles, undergoes into spasm, any muscle undergoes into spasm, the symptom will be pain. Hence, can we say mu receptor causes abdominal colicky pain? Similarly, if the spasm of gallbladder, the gallbladder neck also has a sphincter, it can lead to biliary colicky pain, which is also known as biliary colic. And last, they increase prolactin level. Prolactin level is increased. So just focus, they can themselves cause colicky pain. Now, what about kappa receptor? Remember, kappa receptor, everything is same like mu receptor. It is same like mu receptor except one. Remember, instead of euphoria, kappa receptor rather produce dysphoria. So this is a characteristic effect of kappa receptor. Instead of euphoric feeling, they call dysphoria. Now, what do you mean by dysphoria? Dysphoria means they can lead to psychosis, which is also known as hallucination. So, which receptor produces psychosis or hallucination? That is kappa receptor. Now, what about delta receptor? That is enkephalin. Delta receptor also produce analgesic effect. So, all receptors, they produce analgesic effect, pain relieving property. Which receptor produce convulsions? This is a specific effect of delta receptors. Now, they also produce respiratory depression, cause of death. And just like mu opioid receptors, they also produce constipation. Now, the point is, which is a specific effect of delta receptor we have to remember is convulsions. And which specific effect of kappa receptor we have to remember is dysphoria, that is psychosis and hallucination. Now the question comes, a very famous drug, morphine. Morphine acts on which receptor? So you can easily guess now, M for morphine, M for mu opioid receptor. So we will be discussing this question that morphine acts on mu receptor. It's a full agonist at mu receptor. That is why endogenous opioid we have named it as endomorphine. So if somebody will ask you, what are the effect of morphine in our body? You can remember a mnemonic, sacrum no gap. So that is why morphine is a highly addictive molecule, pinpoint pupil, respiratory depression. So remember, sacrum no gap. So can we say, what is the main use of opioid-like drug? The main use of opioid-like drug is they are analgesics. Analgesics means they are used as a painkillers. And in fact, among all drugs we are having, opioids are the most effective painkillers we have. They are the most effective painkillers or analgesic drugs we have. So why they are the most effective painkiller? Because they act at all levels. All level means that they act at peripheral level, they act at spinal level, and above spinal cord, they act at supraspinal level, and they reduce pain transmission. So let's understand this part. Imagine you have pain in hand, let's say in muscles of the hand. So first point is the sensory nerves, they will go to the spinal cord. In spinal cord, there is an area which carries pain fibers, that is substantia gelatinosa. So at the spinal level, remember the reflex response to the pain will be there. Let's say if I will give pain, you will suddenly withdraw the hand. So at this area, the reflex response to the pain can arise. Now above spinal cord, these nerves, they will enter into the brain. And then these nerves, they will go to the brainstem. And remember, in brainstem, there is associated symptoms of pain. There is autonomic nervous discharge. Don't you think when there is severe pain, our blood pressure increases, heart rate increases? So pain sensations are associated with autonomic features which arise in brainstem. And when these nerves, they will finally go to the uppermost level of the brain, that is cortical level or limbic level. Here we understand what type of sensation pain is. So here the perception or understanding of the pain is there, and we know the pain is associated with emotion. We feel disturbed, sometimes we cry. So at this level, the perception of pain arises. Now, when we give opioid, remember opioids, they inhibit pain transmission at peripheral level. They inhibit substantia gelatinosa or spinal cord level. They reduce the autonomic symptoms of pain at brain stem level. And lastly, they also reduce the perception of pain or the emotional component of pain. So that is why opioids are the best or the most effective painkillers we have. So question arises, in which type of pain would you like to give opioid? In mild pain or severe pain? Remember, in mild pain, we generally avoid giving opioids because they are highly addictive drug. So we only give opioids in severe pain, moderate to severe pain. Now, how we can see this degree or severity of pain? How we can assess? We ask the patient that how much severe pain you are feeling. And we use a chart which is known as VAS chart. VAS stands for Visual Analog Scale. So we ask the patient that rate your pain you are feeling right now. So we ask the patient either to mark the symbol of the face, that whether you are having no pain, mild pain, moderate pain or severe pain. So we tell the patient to put the finger on this particular face, or if the patient cannot do it, if the patient is educated, we tell the patient to mark the number from 0 to 10 that how much severe pain it is. So 0 to 1 is generally no pain or mild pain, 2 is mild pain, 3, 4 and 5 are generally moderate pain, 6, 7, 8, 9, 10 are severe pain. We don't have to remember this vast scale. But we have now understood we can assess the severity of pain by vast scale. Now, if the patient is having mild pain, moderate pain and severe pain, can we say that the pain intensity is increasing? So this chart, this step ladder, which we use is known as WHO step ladder of pain. In WHO step ladder of pain, we classify the pain into mild, moderate and severe. Remember, in mild pain, we give non-steroidal anti-inflammatory drug, which are COX inhibitor. So they are given in mild pain like paracetamol, aspirin, indomethacin, which we have discussed in great detail in NSAIDs chapter. In severe pain, we prefer to give opioids. So can we say that opioids are given in highest stage of step ladder pain of WHO? Now what about moderate pain? In moderate pain, we can combine NSAIDs with some weak opioids. So we can give combination of NSAIDs with weak opioid, and in severe pain we prefer to give strong or very effective opioid for severe pain. So one question arises, sir, what are the causes of very severe pain? So let's write the causes of very severe pain, like cancer pain. So if cancer invades into sensory nerves, it leads to so much severe pain. So the drug of choice for cancer pain is opioids. Similarly, crush injury. Similarly, fracture pain. And lastly, we can remember post-operative pain after doing surgery. So post-operative analgesia, to provide post-operative analgesia, we can use opioid as a drug of choice. So opioids are the drug of choice in all these conditions. Now, opioids are given in virtually all type of pain except one type. One type of pain opioid themselves can cause. So the question comes, opioids like morphine are not given in which type of pain? The answer we already know is colicky pain. We don't give opioid. So you might get an option of like biliary colic. The reason is opioid, they themselves produce spasm of GIT sphincters. Opioid, they themselves can cause colicky pain. Another contraindication of opioid is that opioid is also not given if a patient of head injury comes to us. So if a patient of head injury comes to us, he might be suffering from pain. Due to this head injury, not because of pain, due to this head injury, we avoid giving opioid. So why opioids are avoided in head injury? So let's see the reason why opioids are avoided in head injury. The first reason is opioid, they produce respiratory depression. Now, don't you think because of respiratory depression, the carbon dioxide will accumulate in the body? And carbon dioxide produce vasodilation in brain. And if there is vasodilation in brain, more blood will filter, more plasma will filter, and filtration of plasma will lead to CSF production. And if there is more CSF production, can we say intracranial pressure will increase? So can we say intracranial pressure is increased by opioid? And in head injury patient, we never increase intracranial pressure, we rather reduce intracranial pressure, because increase in intracranial pressure will further compress the brain and patient may die. So because of this reason, in one word, they increase ICP. Because of retention of carbon dioxide, we avoid giving opioids in a patient of head injury. Another reason is we opioid giving in a patient of head injury because in head injury, we assess the severity of head injury by a scale that is known as Glasgow Coma Scale. So in Glasgow Coma Scale, where we assess the severity of head injury, one of the component is we give painful stimulus to our patient of head injury and we see his or her response, whether the patient will withdraw, whether the patient will not withdraw. Now imagine, opioids are painkiller. If you will give painful stimulus, can you assess the response of the patient in Glasgow Coma Scale? The answer is no. Why we don't give opioid in head injury? Because opioids, they interfere with Glasgow Coma Scale assessment of head injury. So these are the two reasons we don't give opioid in head injury patient. Now let's talk about what are the different drugs we have in opioids. So in opioids, we classify the drugs on the basis of on which receptors they are acting. So the first class of drug we have classified as the drug which will act on mu receptor. So mu receptor acting opioid. But we know there are two other receptors also, that is mu, kappa and delta. So if an opioid is acting on kappa and delta receptor as well, then we call them as mixed acting opioid. So in mixed acting opioid, they will act on other receptor as well. That is why the word mixed is there. So first, let's focus on the drugs that are mu receptor acting opioid. So the mnemonic is MCP, FMT. M for a very famous drug which we are going to discuss in great detail is morphine. The brother of morphine is codeine. So we know that these two drugs are natural drugs. But now we have synthetic opioids as well. So in synthetic opioids, we can remember pethidine and propoxyphene. Then a group known as fentanyl group, very commonly used nowadays among opioids. Then we have methadone. And lastly, tramadol. So these drugs we are going to discuss. Now before starting individual drug, let's compare their potency. So remember, morphine is a reference drug, or you can write prototype drug, and we compare all other drugs with respect to morphine. So let's say if the potency of morphine is 1, let's say we have to give 1 milligram of the dose, let's say take an example. Codeine is 1/10 times less potent as compared to morphine. Less potent means it is less powerful. That is why we have to give 10 times more dose of codeine. Then pethidine and propoxyphene, 1/8 times less potent than morphine. Fentanyl group, more than 100 times more potent than morphine as compared to morphine. Similarly, tramadol and tapentadol 1/3 times less potent than morphine. Now, if I'll ask you a question, overall, which is the least potent opioid? What should be your answer? So, overall, least potent opioid is codeine, followed by pethidine and propoxyphene. Similarly, if a question comes, which of the following is the most potent opioid? Can we say we have to find this drug from fentanyl group? And there is a drug which is a brother of fentanyl, that is sufentanil, which we are going to discuss, will be the most potent opioid. So keeping these things in mind, let's start with the first drug, that is morphine. So morphine, from where this name has come? This name morphine has come from Morpheus. And Morpheus is the Greek god of dreams and sleep. So that is why morphine word has come. Now it is a sedative drug, so a person will sleep and person will dream. So we have kept the name morphine. So we know that morphine is used as an analgesic drug. All opioids are used as an analgesic drug, painkiller. But apart from analgesic, what are the additional uses of morphine? Remember, morphine is given in MI, myocardial infarction, and morphine is also given in acute left ventricular failure. So if left ventricle is fail, where the blood will be collected? Blood will be collected in lungs. It will lead to pulmonary edema. So let's see why morphine is given in MI patient. The reason is in MI patient, morphine has a cardioprotective effect. How morphine has a cardioprotective effect? Let's see the reason for it. When we give morphine, morphine decreases heart rate, just like vagus nerve. Can we say if heart rate is reduced, that will decrease oxygen demand of the heart? Because it decreases oxygen demand of the heart, can we say the risk of MI is reduced? MI occurs because of less oxygen supply. So it will decrease oxygen demand. That is why morphine has a cardioprotective effect. That is why we give morphine in MI. Another reason why we give morphine in MI is that morphine also decreases chest pain, which occurs during MI. It also decreases anxiety, or you can write feeling of apprehension. Now, anxiety and apprehension occurs because of increase in sympathetic activity during MI. Morphine has opposite effect. It has parasympathetic activity just like vagus. So it reduces this anxiety or apprehension that patient has a feeling that I'm going to die suddenly, impending doom feeling. That is also reduced by morphine. So that is why morphine is given in MI. Now morphine is also given in left ventricular failure or pulmonary edema because morphine reduces preload. So preload means the blood which is going to the right part of the heart. From right part, now it will not go to the lungs and pulmonary edema will clear off. And why it reduces preload? Because it has venodilatory effect. Agreed? So let's make one list of the drugs which will have effect on heart rate. So can we say the first is morphine? And we know morphine decreases heart rate. That is why morphine is given in the treatment of MI because of cardioprotective effect. Second point, we have fentanyl. Fentanyl has no effect on heart rate. So it is heart rate neutral drug. Yes, it can be given in the treatment of MI. It will not have cardioprotective effect, but yes, it will reduce chest pain. But the third one is very important. Two drugs, pethidine and pentazocine. These two we have to remember. Pethidine and pentazocine, remember, they rather increase heart rate. Now, because they increase heart rate, can you tell me what will happen to the oxygen demand of the heart? Can we say they rather increase oxygen demand? Because they increase oxygen demand, which opioids are absolutely contraindicated in MI patients? That is, pethidine and pentazocine should never be given. Two opioids never given in MI patient because they increase heart rate and rather increase oxygen demand. So this is the opioids which are used in MI. So let's talk about morphine routes. Remember, morphine can be given by all routes. Like it can be given orally, it can be given IV, it is given sublingually as a transdermal patch, it can be given intrathecally, Now the point is, oral morphine can be given, IV and sublingual morphine are given for acute pain, to relieve acute pain. While transdermal patch which are applied on skin, can we say they deliver a drug continuously? So transdermal patch are given for chronic pain, like cancer pain. While intrathecal administration of morphine also reduces pain from the brain, but intrathecal injection has a side effect. Intrathecal injection of morphine can lead to hypotension because it reduces sympathetic nerve supply directly. Now the question is that morphine is given by all routes except morphine is never given intranasally. So there is only one opioid which is given intranasally or inhalationally. That I am going to discuss shortly. Now, how morphine is metabolized? Remember, morphine is metabolized by a process known as glucuronide conjugation. Glucuronide, when attached with morphine, converts morphine into water-soluble form. And this water-soluble form of morphine, it is excreted in urine. It is excreted in urine. So let's see first point. What are the products which are produced when morphine is attached with glucuronide? So first point is that when morphine is attached with glucuronide, the first product which is produced is morphine 6-glucuronide. And one more product is produced, morphine 3-glucuronide. Now, which is a bigger number? 6 is a bigger number. So we will write that morphine 6-glucuronide is the major active form of morphine. So morphine 6-glucuronide produce pain relieving effect. It is the major active form of morphine. So which is the minor form of morphine? Minor form of morphine is 3-glucuronide. It is the minor form. It is produced in very less quantity, but this morphine 3-glucuronide is a harmful molecule. It can lead to convulsions, especially in children, because this 3-glucuronide is mainly produced in children in greater amount. So this 3-glucuronide is a harmful product. All these glucuronide are excreted in urine. So can we say morphine-like drugs should be avoided in renal failure patient because they will accumulate morphine 3-glucuronide, morphine 6-glucuronide, which can lead to respiratory depression. So question comes that which opioids are contraindicated in renal failure? One of the opioid we already know is morphine. Two other opioids we will write PCM. Total 3 opioids are contraindicated in renal failure. So P stands for pethidine. We will see the reason for it with pethidine. Second is codeine. I will tell you codeine gets converted into morphine only. And the last drug is morphine. So 3 opioids contraindicated in renal failure is PCM, pethidine, codeine and morphine. Now let's talk about that morphine we know is an alkaloid. We know that morphine is an alkaloid. Alkaloid means it is a basic drug. And remember, all basic drugs, they have a property that they can release histamine from the mast cells. Why? The reason I'll tell you, suppose this is a mast cell. In mast cells, remember, histamine, it is attached to a molecule known as heparin. Heparin, it is an acidic molecule and histamine is a basic molecule. So when we give any basic drug to our patient, can we say basic drugs when given from outside, they will attach to heparin? acid and base, they attach among themselves, and this histamine will become free. And this histamine is released from the mast cell. So all basic drugs, they can cause release of histamine from the mast cell, which we have discussed in heparin section, like morphine, vancomycin. Vancomycin causes histamine release, which leads to red man syndrome. Now, because morphine causes histamine release from the mast cell, morphine produces a side effect of allergic reactions like asthma. It can also lead to intense pruritus because of histamine release from the mast cell. So avoid morphine in a patient of asthma and pruritus. Remember, it's a side effect. It is not a contraindication. Contraindication of morphine was head injury. So these are the side effects of morphine. So this is about morphine. Now one question, that when we give morphine, morphine produce meiosis or pinpoint pupil. Now, morphine produce pinpoint pupil or meiosis by which route? Is it oral route or eye drops? So, let's understand that how morphine produces meiosis. So, suppose this is brain. In our brain, we have a nucleus that is EDW, Edinger-Westphal nucleus. Edinger-Westphal nucleus. Now remember, from Edinger-Westphal nucleus of the brain, oculomotor nerve arises, which is the third cranial nerve. And this oculomotor nerve, it goes to eyes. And in eyes, there is iris. And on iris, they will produce meiosis. How? Remember, oculomotor nerve, they release acetylcholine. And acetylcholine acts on M3 receptor, that is muscarinic 3 receptor, which leads to contraction of sphincter pupillae muscle in iris, which leads to meiosis or pinpoint pupil. Now, where does morphine acts? Remember, morphine stimulates Edinger-Westphal nucleus in brain. Morphine stimulates Edinger-Westphal nucleus in brain. And any drug which acts like acetylcholine, like cholinergic drugs. So, cholinergic drugs like pilocarpine, organophosphate, they act on M3 receptor of iris and produce meiosis. So, the question is, in which route morphine will produce meiosis? When we give eye drops of morphine, remember, morphine does not act on iris. Morphine does not act on iris. So, when you give oral morphine, remember, oral morphine produce meiosis because oral morphine will enter into the brain and stimulate Edinger-Westphal nucleus. So, here comes the question, that in which poisoning pinpoint pupil is seen? Pinpoint pupil, it is seen in the poisoning of, first is opioid poisoning, and second, organophosphate poisoning. So, in these two poisoning, pinpoint pupil is seen, but the reason of pinpoint pupil is different. Morphine acts on brain, Edinger-Westphal nucleus, that will stimulate oculomotor nerves. Now, this is about morphine. Let's see a drug which we have derived from morphine. So, we have modified morphine, we have attached acetyl group to the morphine, and we have made a semi-synthetic derivative, diacetyl morphine. So, diacetyl morphine is a semi-synthetic derivative. It is 10 times more potent than morphine. Now, imagine if a person is a smuggler who wants to smuggle and supply these drugs to their person, to their customers. giving morphine is better or giving diacetyl morphine is better? Don't you think diacetyl morphine is 10 times more potent? Person will require lesser dose and it is easy to smuggle. So this diacetyl morphine, smugglers, they used to call it as smack. It is also known as heroin. It is also known as brown sugar. So this drug is addictive drug, it is abusive drug. Smugglers, they supply this diacetyl morphine. Now when this diacetyl morphine or heroin, it is mixed with cocaine. Cocaine is also a smuggled drug. Smugglers, they give abusive drug. This combination is known as speedballs. It is known as speedballs. Now let's talk about codeine, another natural opioid obtained from Papaver somniferum plant. Remember codeine, it is also known as methyl morphine. And this codeine, its active form is morphine. And inside the body, codeine gets converted into morphine by CYP2D6 enzyme. CYP2D6 enzyme. How we can remember? D means dimag, dimag means brain. So codeine and morphine, dimag wale drugs, they are converted into by active form by CYP2D6. Now how codeine is different from morphine? Remember codeine is 1 by 10 times less potent analgesic as compared to morphine. That means it is a less powerful analgesic, but it is equally powerful antitussive drug. Antitussive means it acts on brain and suppress cough centers. So it is an equally effective cough suppressant as compared to morphine. So the main use of antitussive drug is antitussive drugs like codeine, they are given in the treatment of dry or non-infective cough, which we have discussed in respiratory system in great detail, antitussive. So let's make the list of the drugs among opioids which are used as an cough suppressant or antitussive. So the first drug is morphine. Morphine syrups are there. Similarly, codeine syrups are there. So these are natural drugs. Now we have modified them, and from morphine we have made oxymorphone, a derivative of morphine. So similarly, from codeine we have made oxycodone. From morphine we have made hydromorphone. Similarly, from codeine we have made hydrocodone. From morphine we have made a different name drug, levorphanol. And from codeine we have made pholcodeine. Now, why we have made these derivatives? The great advantage of this pholcodeine and other derivatives is they have less risk of causing constipation. Less risk of causing constipation. Now, there is a big problem worldwide that people, they abuse cough syrup. So, these cough syrup abuse is seen because these cough syrups, they contain opioid, and opioids are highly addictive drugs. So, addiction is seen. That is why we have made non-addictive antitussive drugs. So we have made now non-addictive antitussive drug. They are also derivative of opioid, but they will not act on opioid receptor. So the first drug we have to remember is dextromethorphan. So what is dextromethorphan? It is a cough suppressant or antitussive, and second drug is noscapine. So dextromethorphan, instead of opioid receptor, dextromethorphan blocks glutamate receptor. It is an NMDA antagonist. while noscapine acts on some unknown sigma receptors, which we don't have to go into detail, and stimulate sigma receptor. So the great advantage of making this dextromethorphan and noscapine is that they are non-addictive, and another great advantage is they are non-sedative as well. While opioids are sedative and addictive, dextromethorphan and noscapine antitussives are non-addictive, non-sedative. So now let's talk about next opioid, that is a synthetic derivative, pethidine. Now pethidine is also known as miperdine. Why it is known as miperdine, we will discuss. Now the first point is that pethidine acts on mu receptor, it stimulates mu opioid receptor, but it has additional property. Pethidine has additional anticholinergic effect. It means it blocks acetylcholine receptors. Just like a drug, atropine-like property. Okay, so importance we will see. So remember, with pethidine, remember 3P. The first P with pethidine is pregnancy. In pregnancy, it is the safest opioid we have. It is the safest opioid in pregnancy, pethidine. Next P stands for post-anesthetic shivering. And here also the drug of choice is pethidine. Now what is post-anesthetic shivering? Let's say after anesthesia or after the surgery is over, the patients wake up and patient has shivering because of dysregulated temperature centers. Temperature centers right now have not recovered properly. Patient has shivering due to excessive heat loss. When we give opioid like pethidine, they regulate our temperature center and shivering is gone. And last point P with pethidine is that pethidine is a prodrug. So pethidine is a prodrug. Now let's talk about how pethidine is a prodrug and how pethidine is converted into active form. So pethidine is a prodrug. It gets converted into two active form. The first active form of pethidine is miperdine. Because it is making miperdine as an active form, which act as an opioid analgesic property, its another name is miperdine. So it's a good thing. And another form which is produced from pethidine is norpethidine. But this norpethidine is the toxic form of pethidine. Remember, it has a side effect of scissors. It has a side effect of scissors. Now the point is, pethidine gets converted into norpethidine with the help of an enzyme, MAO enzyme. MAO stands for monoamine oxidase enzyme. Now think for a second and tell me the answer of this question, that why pethidine is never combined with MAO inhibitors. So if you combine pethidine with MAO inhibitor, can we say that miperdine will not be produced? With MAO inhibitor, what will be produced? Norpethidine will be produced in excess amount and it can lead to seizures. That is why pethidine is an opioid never combined with MAO inhibitor. Second point we have discussed with pethidine has that pethidine has additional anticholinergic effect like atropine. And beta, we have discussed that atropine blocks vagus nerve supply to the heart. Because of this reason, pethidine causes tachycardia. Tachycardia means increase in heart rate, and any drug which increases heart rate will increase oxygen demand of the heart. That is why pethidine is contraindicated in MI patients, myocardial infarction patient. Second point we have discussed in atropine chapter, Anticholinergic drugs, remember, they relax GIT sphincter. They relax GIT sphincter. That is why pethidine is an opioid which will have least risk of causing colicky pain. So if you remember, morphine causes bradycardia given in MI, but morphine is contraindicated in colicky pain because it causes spasm of sphincter. Pethidine is opposite. Pethidine relaxes GIT sphincter, so it will have least risk of causing colicky pain. So these are the important points with pethidine. Now let's talk about fentanyl group. Among them, we have various drugs ending with the word fentanyl. So the first drug we have made is fentanyl. Fentanyl is almost 100 times more potent than morphine. So don't you think we have to give very less dose? Remifentanil, 50 times more potent. L-fentanyl, again, 50 times more potent. But let's talk about this drug, sufentanil. Sufentanil is almost 1000 times more potent than morphine. That means the most powerful drug is sufentanil. So we will write that sufentanil overall is the most potent opioid. And second point with sufentanil is also maximum plasma protein bound opioid. And any drug which is attached to plasma protein is not excreted in urine. That is why all these opioids are safe in renal failure. In renal failure, we discussed 3 opioids which are avoided: PCM, pethidine, codeine and morphine. Now let's talk about 2 drugs in great detail. One is fentanyl and second is remifentanil. So first is fentanyl. Fentanyl is a highly lipid soluble drug. So it's a highly lipid soluble drug. That is why it has a very good brain entry. That is why it is the most potent opioid. But being a highly lipid soluble drug, remember, fentanyl after coming out from brain, it shows redistribution into fats. It becomes deposited in fats. So even after stopping fentanyl, because fentanyl is still in fats, the action of fentanyl does not get over very soon. From fats, it will come back into the blood and stimulates brain. So I told you a similar drug which shows redistribution into fats, that was thiopentone. We discussed this concept with thiopentone in general pharma and general anesthetics in great detail. Now, what is the route of administration? Fentanyl is given by many routes, except by which route we don't give fentanyl. A recent question. Fentanyl is not given by oral route, because when you give fentanyl orally, fentanyl has very high first pass metabolism in liver. So F for fentanyl, F for first pass metabolism in liver, it means liver degrades fentanyl. So what are the routes of administration of fentanyl? Fentanyl is given by transdermal patch, because all other routes, they bypass the first pass metabolism of liver. It is also given as sublingual tablets, buccal tablets, and toffees like lozenges. Fentanyl can also be given intravenously and as an epidural injection. Okay. So as a transdermal patch, it's a very commonly given used drug for long-term treatment of pain like chronic cancer pain patients. As a sublingual or buccal tablet, it has a very fast onset of action. It is given for acute painful condition. Similarly, IV and epidural injections, it can be given as a spinal analgesic, as an epidural injection. Now, one rare side effect of fentanyl. Fentanyl causes contraction of muscles of chest wall. And this syndrome or rare side effect of fentanyl is known as wooden chest syndrome. So, in wooden chest syndrome, there is truncal, that means chest wall muscle rigidity, a rare side effect of fentanyl. Now, let's talk about the brother of fentanyl, remifentanil. So, remifentanil overall is the shortest acting opioid, because when we give remifentanil to our patient, in the plasma, there is an enzyme known as plasma esterase enzyme. So, as it comes into the blood, plasma esterase enzyme rapidly metabolize or degrade remifentanil. So, it is rapidly metabolized or degraded by plasma esterase enzyme. So, similarly, I have told you shortest acting beta blocker was ismolol. Shortest acting opioid is remifentanil because they are degraded by plasma esterase enzyme. Like one beta blocker, ismolol. Ismolol was the shortest acting beta blocker. So, one question, shortest acting opioid is remifentanil. So, which is the longest acting opioid? Longest acting opioid we are going to discuss after it will be methadone. Methadone, longest acting, remifentanil, shortest acting. So, because it's a short acting opioid, can we give this opioid in daycare surgeries? So, it is given in daycare surgeries. Daycare surgeries means we admit the patient and on same day we discharge the patient. So, these are very minor surgeries. So, remember, during daycare surgery, in minor procedure, those minor surgery we have to give one general anesthetic drug to make the person unconscious. So, drug of choice as a general anesthetic in daycare surgery is propofol. So, propofol, very rapid onset of action, person becomes unconscious, we can do surgery. But propofol is not an analgesic drug. It does not have pain relieving property. So, what is the analgesic drug of choice during daycare surgery to relieve pain? That is remifentanil. So, remifentanil is combined with propofol. Similarly, which skeletal muscle relaxant can be given in daycare surgery? Very short acting drug, mivacurium. So, these are the respective drugs used during daycare surgery: general anesthetic, analgesic, and skeletal muscle relaxant. So, this remifentanil, it is very commonly combined with propofol during daycare surgery. One more condition where they are combined together is TIVA, that is total intravenous anesthesia. So, this is also a similar thing. We combine remifentanil with propofol. Now, let's talk about next drug, methadone. So, methadone has a mu agonist action, but it also has one additional action. It blocks NMDA receptor of glutamate. Because it blocks NMDA receptor of glutamate, methadone has a side effect that methadone can cause QT prolongation on ECG. So, on heart, there is QT prolongation. So, question comes, which opioid causes QT prolongation? That is methadone. So, methadone has additional NMDA antagonist property, and we know methadone is the longest acting opioid. So, the half-life of methadone is 40 hours. Now, when we give methadone orally, remember, oral methadone, when you will give, its action will start in 30 to 60 minutes. And when you give IV methadone, its action will start in 10 to 20 minutes. Now, just focus on this part. When you give oral methadone, can you tell me the action will come like this A or the action will come like this B? How the action will come? Can we say methadone when we will give, its action will start very slowly and it will be very long acting drug. Because of this reason, methadone will show property like B. Because it has property like B, methadone is mainly given in opioid de-addiction. Because when the opioid they produce sudden effect, there is pleasure and the person becomes de-addict. And when we stop opioid, the patient goes into withdrawal. So any drug which is a very short acting drug will show pleasure and withdrawal. So when we give methadone, see this part, in a patient of opioid, can we say methadone will not lead to pleasure? It will not lead to withdrawal. So any drug which is a very long acting drug is given in opioid de-addiction. So methadone is given in opioid de-addiction to prevent opioid withdrawal. And overall, I will be telling you 3 drugs which are given in opioid de-addiction to prevent opioid withdrawal. Those 3 drugs will be BMT, bone marrow transplant. So B for buprenorphine, which we are going to discuss. M for methadone. And recently approved drug is tramadol. These 3 drugs are approved for opioid de-addiction. So opioid de-addiction, we give these drugs. Now let's talk about next drug, very commonly used in home and hospital setting, tramadol. And similar to tramadol, a new drug has been approved, tapentadol. So tramadol has which additional property? It's a mu agonist, plus it has SNRI-like effect. SNRI stands for, it is a serotonin, norepinephrine, reuptake inhibitor. So if serotonin and norepinephrine are not removed or reuptake, can we say the levels of serotonin and norepinephrine is increased in the brain? So it increased the level of serotonin and norepinephrine. Now tramadol is a very weak analgesic because in mu agonist, it is not a full agonist, it is rather a partial agonist. So because it has a very weak property, can we say it will not lead to intense pleasure? Agreed? That is why it was also given in opioid de-addiction. Now the point is, it's a very weak analgesic. Hence, it is usually combined with non-steroidal anti-inflammatory drug like paracetamol we can combine with tramadol. And it is given for mild to moderate pain. So weak opioid, almost moderate pain. Now what is the main side effect of tramadol? We know that tramadol increases serotonin level and serotonin causes nausea and vomiting. And remember, serotonin in our body, it is degraded by MAO enzyme. So can you tell me, if we give MAO inhibitor, tramadol should never be combined with MAO inhibitor. Why? Because the levels of serotonin will increase drastically. It will lead to serotonin syndrome. So if you will combine tramadol with MAO inhibitor, we should avoid it. It will lead to serotonin syndrome, which can be very dangerous. So this is all about the drugs, opioids, which were acting on mu receptor. Let's talk about mixed acting opioid. So mixed acting opioid will act on other receptors also, like kappa and delta receptors. So the first class of drug we are having is partial kappa agonist with the mu antagonist. So our first goal is to remember the names of drug. So in this class we have three drugs, PNB, Punjab National Bank, P for pentazocine, nalbuphine and butarphenol. We are going to discuss these drugs one by one, but among them, try to remember pentazocine. It has been asked commonly, it's a partial kappa agonist. Now, from this part, just remove this mu antagonist. If you will remove this word mu antagonist, what it will become? It will become pure kappa agonist. So, it will become pure kappa agonist. And the drugs are Phena, F for pheidotosine, iloxadoline, nalfurafine and acemadoline. Till now, these drugs have not been asked, so you can skip this part. Now, let's make it opposite. So, the first one we have written as partial kappa agonist and mu antagonist. Let's make them opposite now. So, if we will make them opposite, what it will become? It will become partial mu agonist and kappa antagonist. And the drugs are very frequently asked. The drug name is buprenorphine. Buprenorphine is a partial mu agonist, kappa antagonist and dizocine. So the drugs which I have marked as question, you must remember those drugs. Lastly, we have a class of a drug which is a pure antagonist. Pure antagonist means they will block all receptors. These drugs are competitive blocker of all three receptors, mu, kappa and delta, and they will have null word in them. Null word means naloxone, naltrexone and nalmefene. And these three drugs we have to remember, they will have null word in them. So keeping this thing in mind, these are the other opioid. Let's start with individual drug. First is partial kappa agonist and mu antagonist. Three drugs, PNB, pentazocine, nalbuphine and butarphenol. Now, first point. Can you think for a second that these drugs are pure partial kappa agonist? Because of this reason, these drugs have a side effect of psychosis or dysphoria. Because we have discussed kappa receptor stimulation leads to dysphoria. So which opioid produce psychosis or dysphoria? PNB, pentazocine, nalbuphine and butarphenol. Now these drugs are mu antagonist. Remember, these drugs, because of mu antagonist property, they are never given in morphine or opioid de-addiction. They are never given in morphine de-addiction. The reason is very simple. Imagine when we give morphine, morphine acts on mu receptor and stimulating mu receptor will lead to pleasure. If you suddenly block mu receptor with, let's say, pentazocine, the patient will suddenly go into withdrawal. So they will precipitate withdrawal symptom, and withdrawal are very dangerous. That is why these three opioids are never given in opioid de-addiction and they produce psychosis. So among them, one drug we have to remember in great detail, butarphenol. Butarphenol is the only intranasal opioid we have. So the only intranasal opioid we are having is butarphenol, and this butarphenol is given in the treatment of migraine headache. It has been approved for which pain? Migraine headache. So normally for migraine, we have discussed we use a drug sumatriptan, triptan wale drugs. But if triptans are ineffective, then we give opioids like butorphanol. Then the next drug we have is pure kappa agonist. In pure kappa agonist, they have never been asked, but these are new drugs, potential question for INI-CET, fidotosine, eluxadoline and esimadoline. These three drugs, remember, they are approved in the treatment of diarrhea, to control diarrhea in irritable bowel syndrome. They have been approved for irritable bowel syndrome. While this nalfurafine, so it has been approved to control pain due to uremic pruritus in CKD patients. Then we have a drug, partial mu agonist and kappa antagonist. So remember, if morphine is a full agonist, let's say morphine is a full agonist, don't you think morphine will lead to intense level of response, intense addiction? So if I will give partial mu agonist, can we say partial mu agonist will produce less response? Can we say less response means the patient will not go into pleasure, patient will not go into withdrawal also. So that is why buprenorphine, because it has less response as compared to morphine, buprenorphine has been approved for the treatment of opioid de-addiction. Just like methadone we discussed to prevent opioid withdrawal. Now, this buprenorphine is given orally, and this buprenorphine binds to mu receptor in which fashion? Reversible fashion or irreversible fashion? Irreversibly. That means it is impossible to remove buprenorphine from its receptor. Because of this reason, there is no effect of naloxone. Naloxone is an antagonist. It cannot replace buprenorphine from its receptor in buprenorphine overdose or buprenorphine poisoning. Because I will be telling you shortly, naloxone is given in all opioid poisoning except buprenorphine, because buprenorphine binds to the receptor irreversibly. Another drug is dizocine. So dizocine is an IV analgesic drug, and as compared to morphine, it has less risk of respiratory depression. Why less risk of respiratory depression? Because it is not a full agonist, it is rather a partial agonist. And just write one point, it is faster analgesic as compared to morphine. Now, let's talk about the drugs which are pure antagonists. Pure antagonist means they will block. They are competitive antagonists of all three receptors, that is mu, kappa and delta opioid receptor. They block all three receptors, and these drugs, they will start with the word nal. So the first drug is naloxone, naltrexone, and the third drug is nalmefene. Among them, naloxone, remember, is not absorbed orally. Because it is not absorbed orally, it is an IV drug. So naloxone is an IV drug. And where would you like to give IV drug? In emergency or in poisoning? Naloxone is considered to be the antidote for opioid poisoning. Now, naltrexone is an oral drug. Naltrexone is an oral drug. So, because it's an oral drug, it is given to prevent relapse in opioid addiction. That means a person should not start taking opioid again. We can give naltrexone. Now, naltrexone side effect is it is hepatotoxic. That is why we have made a drug nalmefene. Nalmefene is an oral drug, so it has same uses. And the great advantage of nalmefene is that nalmefene is liver safe. It is not hepatotoxic, and nalmefene can be given IV as well. That means sometimes it can be used for the treatment of opioid poisoning as well. But remember, the drug of choice you have to remember is naloxone and naltrexone. Nalmefene is a new drug which has certain advantages. Remember naloxone and naltrexone. Recently, other new drugs have been approved, which we are going to discuss. And these new drugs are also like naloxone, naloxegol, nalmefene. So these are the new drugs which we are going to discuss. So keeping this thing in mind, let's talk about opioid addiction. So imagine a patient who has taken very high dose of opioid comes to you. What will be the symptoms of opioid poisoning? So remember sacrum no gap mnemonic we have discussed. So patient will be sedated. Sedation means patient will be sleeping or the patient will be unconscious. Then all the secretions of the body are reduced. So dry secretions. So patient will have dry eyes, dry mouth. Agreed? Patient will have constipation instead of diarrhea. Patient will have urinary retention. So all the secretions are reduced. Third point, patient will have meiosis. And this will be written in your question as pinpoint pupil. Pinpoint pupil. Now, patient can have convulsions as well because of delta receptors. And lastly, what is the cause of death? The cause of death is respiratory depression. Okay. Now imagine a patient who is taking opioid chronically. One day he doesn't get opioid. Don't you think the person will go into withdrawal symptom? And remember, withdrawal symptoms are opposite of the main effect of any drug. So symptoms of opioid poisoning and symptoms of opioid withdrawal will be opposite. So instead of sedation, the person will be highly excitable. Can we say there will be increased secretions like sweating, excessive salivation? Similarly, diarrhea and excessive urination can also be there. Instead of meiosis, the patient will have mydriasis. Lastly, instead of respiratory depression, patient will have air hunger, yawning. So yawning is sometimes asked. Now the question comes, which of the features is not seen in opioid withdrawal? Remember, there is no convulsions. Convulsions are not seen in opioid withdrawal. Because convulsions are due to opioid, withdrawal will be opposite. So convulsions are not seen. So this could be a question. So we all know that in any drug addiction, there is development of tolerance. Tolerance means with time the effect of that drug reduces. That is why person takes a drug in higher dose and the person becomes addicted. With opioid, tolerance develops to all effect like euphoria, etc. But tolerance do not develop to three effects of opioid. 3C are convulsions. With convulsions, tolerance is not seen. Second is constipation. And third C is constricted pupil, which we can write it as meiosis. So these are the three effects to which tolerance, that means with time the effect does not reduce. Now this is a very important slide. Let's talk about how to manage a patient of opioid addiction. So imagine a patient of acute overdose or acute morphine poisoning comes to you. We already know the symptoms of morphine poisoning or opioid overdose. What is the antidote? The drug of choice for opioid antidote is intravenous naloxone. Because naloxone will produce opposite symptoms. So can you think what will be the effect of naloxone? Naloxone will have effects similar to withdrawal symptom. That means it causes respiratory stimulation. It will cause mydriasis. It will not produce convulsion. So effect like withdrawal will come. So person will start breathing. That is why we give overall antidote of opioid poisoning is naloxone. Now after you have stabilized the patient, the next phase is maintenance phase. Why maintenance phase? Because if a patient is opioid, the patient can go into withdrawal. So we have to give a similar opioid-like drug which we will taper off slowly, and hence the patient will not go into withdrawal. So this phase is known as maintenance phase or detoxification phase. The main work of this phase is to prevent withdrawal, and to prevent withdrawal, 3 drugs are approved, which we have already discussed. BMT. So to prevent withdrawal, 3 drugs are given. BMT, B stands for buprenorphine. Methadone and tramadol. So these 3 opioids are given to prevent opioid withdrawal because they are very long acting and less effective drug. But what happens in rehabilitation centers normally, we tell our patient to take, let's say, 1 tablet of tramadol. Now the patient is getting opioid from doctor for free. Patient will take 5 tablets, 10 tablets, and the person will start abusing these opioids. This is a big problem. That is why we have made certain new non-opioid drugs. Because these non-opioids will not have addictive potential. BMT, buprenorphine, methadone, themselves person can start abusing again. So those non-opioids given to prevent opioid withdrawal are clonidine, and a new drug is approved, lofexidine. These 2 drugs, they stimulate alpha-2 receptors in brain, which we have discussed in autonomic nervous system, and they also prevent opioid withdrawal. Now slowly and slowly you have tapered off these drugs like buprenorphine and methadone, and now the person is totally de-addicted. So now you have stopped them. Now imagine, this person went to a party and his friends are taking opioid. If his friends are taking opioid, so don't you think patient can start taking again? Start taking again means the person can again have relapse. He may start taking again. So after this maintenance phase, when the maintenance phase is over, we give a drug to prevent relapse or to maintain abstinence. And to maintain abstinence, we give the drug oral naltrexone. Because naltrexone blocks opioid receptor, even if a patient will now start taking morphine or opioid-like drug, the receptors are already blocked. The pleasurable effect of opioid will not come. So block this receptor by giving oral naltrexone. So just focus on this slide and see the difference where IV naloxone is given and where oral naltrexone is given. Remember, IV naloxone for acute opioid poisoning, and oral naltrexone is given to prevent relapse after maintenance phase. Now, keeping this thing in mind, we know that opioids, they produce constipation. Why? Because opioids, they reduce intestinal motility or intestinal peristaltic activity. That is why opioids are anti-motility drug. Because they are anti-motility drug, opioids are given in the treatment of diarrhea. And the first drug is loperamide. How we can remember loperamide? OP word is coming. So loperamide is a opioid. OP word is coming. And loperamide acts on mu receptor. So it's a mu agonist. The great advantage of loperamide is a non-addictive opioid. It has no addiction. Why it has no addiction? Because loperamide, it is not absorbed from GIT. And loperamide cannot cross blood-brain barrier. So it cannot enter into the brain. It's a non-addictive opioid. That is why loperamide now is considered to be the drug of choice for diarrhea. It is now considered to be the drug of choice for diarrhea. Remember, any cause of diarrhea, we prefer to give which anti-motility drug? Loperamide. Let's see certain causes of diarrhea, like diarrhea in IBS, irritable bowel syndrome, diarrhea in cholera. Can we write drug-induced diarrhea? So one anti-cancer drug which causes diarrhea is irinotecan-induced diarrhea, a specific question. So everywhere drug of choice is loperamide. Now, before loperamide, we had a drug diphenoxylate. Problem with diphenoxylate is it is also a mu receptor agonist just like loperamide, but diphenoxylate is an addictive drug. Addiction was there. Why? Because it can cross blood-brain barrier. So the question came, recent question. To reduce this addictive potential of diphenoxylate in earlier times, we used to combine diphenoxylate with a drug atropine. Diphenoxylate is combined with atropine. Why it is combined with atropine? To reduce addiction. How atropine reduce addiction? Remember, atropine, it reduced the absorption, GIT absorption of diphenoxylate. So if GIT absorption is reduced, the addictive potential of diphenoxylate is reduced. Another drug, just for the reference, we have to remember diphenoxin, similar to diphenoxylate. Acimidolene, eluxadolene, fidotozine, they are kappa agonists. And these drugs have been approved for the treatment of diarrhea in IBS, new drug for irritable bowel syndrome. Last drug which we have to remember is Resicadrotil. So the drugs which we have shaded, we have to remember Resicadrotil. It is an encaphelinase inhibitor. That means encaphalins will not be degraded now. That means it increased the level of endogenous encaphalins. And beta, we have discussed encaphalins are endogenous opioids. They were acting on kappa receptors, kappa delta receptors. So encaphalins are endogenous opioid and they reduce motility. This Resicadrotil is the safest drug among this class in children. So that is why it is preferred for diarrhea in which age group? Diarrhea in children. So why loperamide is not very safe drug in children? Because in children, the blood-brain barrier is not fully produced, not completely produced. So loperamide do have little bit entry into the brain. So although loperamide is the safest drug, but in children, the safest drug is Resicadrotil. Now beta, we know that opioids, they reduce motility of intestine. They are given in the treatment of diarrhea. So can you tell me opioids themselves can produce? Opioid themselves produce a side effect of constipation. So side effect of opioid is constipation. And that is why we have made drugs for treatment of opioid-induced constipation. So these drugs, they block mu, kappa and delta receptor of opioid in intestine. So these drugs will be blocker. And we discussed all blockers will start with the word nal, naloxone. Naloxone is given orally. In this case, because oral naloxone will not get absorbed, it will just block opioid receptor in intestine. Methyl naltrexone, and the new drug which has been approved is Naldi, Nalmedine, Naloxone, Naloxegol. So these drugs are given orally for opioid-induced constipation, but one name is different. And this question came. Elvimopan. How we can remember Elvimopan? Very simple. OPAN word is coming. Elvimopan is an opioid receptor antagonist. It means it blocks mu kappa and delta receptor. OPAN word is coming. So this drug has specifically been made to treat opioid-induced constipation. So this finishes opioid. Let's make a summary. So natural opioids like morphine and codeine, they are also known as opiates. Opioid receptors are mu, kappa and delta receptors. So morphine acts on which receptor? M for morphine, M for mu receptor. So dysphoria, which is hallucination or psychosis, is produced from which receptor? Mu, kappa or delta? So dysphoria or hallucination is a side effect produced by kappa receptor. Now morphine and opioids are given in all types of pain except colicky pain, like biliary colic, because they themselves can cause spasm of sphincter. So opioids are also avoided in head injury patient. The reason was they increase intracranial pressure and they interfere with Glasgow Coma Scale. In MI and left ventricular failure, morphine is used because morphine reduces heart rate, while pethidine and pentazocine are not used. Because pethidine and pentazocine are avoided because they increase heart rate. Morphine decreases heart rate. Opioids which are avoided in renal failure are PCM. P for pethidine, codeine and morphine. Which drug is a non-addictive antitussive or cough syrup? That is dextromethorphan. It was not acting on opioid receptor, it was acting on some NMDA receptor and noscapine, sigma receptors. Most potent opioid, sufentanil. And least potent opioid, codeine. Longest acting opioid, methadone. While shortest acting opioid, remifentanil. So because methadone was long acting given for opioid de-addiction, remifentanil daycare surgeries. So which opioid acts on mu receptor and NMDA antagonist property? Methadone. That is why methadone was causing QT prolongation. Which opioid has additional anticholinergic action? Pethidine. Which opioid has SNRI-like effect? Serotonin, norepinephrine reuptake inhibitor, tramadol. So pentazocine and butarphenol, they are mixed acting opioid. They were kappa agonist and mu antagonist. Buprenorphine and dizocine, they are opposite. They are mu agonist and kappa antagonist. Naloxone, nalmefene, naltrexone, nal word is coming. They are mu, kappa and delta antagonists. They are pure antagonists. Now, which is the antidote of opioid poisoning? Antidote of opioid poisoning is naloxone. So, antidote of opioid poisoning is IV naloxone. Which drug is given to prevent opioid withdrawal? BMT. Buprenorphine, methadone and tramadol. And which drug is given to prevent opioid relapse? That is oral naltrexone. Now, loperamide is the drug of choice for diarrhea. Why? Because it's a non-addictive opioid. While diphenoxylate, it is an addictive opioid. It is combined with atropine to reduce addiction. And Elvimepan, a new drug which is given for the treatment of opioid-induced constipation. So these are the points you have to remember. Let's solve certain MCQs. So which of the following is the antidote of opioid overdose? We all know the answer, naloxone. So flumazenil, remember, it is the antidote of benzodiazepine like diazepam, lorazepam poisoning. While fomepizole is an antidote of poisonous alcohols like methanol and ethylene glycol poisoning. Pethidine itself is an opioid. Now, which of the following options refer to opioid antitussive that acts centrally in the body? So, which drug is an antitussive drug and it is an opioid? The answer is levorphanol. Remember, diphenoxylate and loperamide, they are not antitussive drug. They are given as in the treatment of diarrhea. Levorphanol is an antitussive drug which is cough suppressant. While ambroxol is also cough suppressant, but it is not an antitussive drug. It is used in cough, but it is an expectorant drug which we have discussed in respiratory chapter. It expels out mucus. Now, which of the following statement regarding pethidine or mipardine is correct? So, pethidine is contraindicated in pregnancy. False. We discussed that pethidine is rather the drug of choice in pregnancy, safest opioid in pregnancy. It is converted into norpethidine, which is responsible for analgesic effect. False. Its analgesic effect is not produced from norpethidine. It is rather produced from mipardine. Okay? Because norpethidine rather produces seizures. It is contraindicated in post-anesthetic shivering. False. It is the drug of choice. For the treatment of post-anesthetic shivering, the option D is correct. It is contraindicated in patients of renal failure. And we discussed 3 opioids contraindicated in renal failure were P for pethidine, C for codeine, and M for morphine. So, fourth option is a true statement. So, now let's talk about last question. Which of the following mixed acting opioid is a partial kappa agonist and mu antagonist property commonly used for migraine headache? Now remember, pentazocine is a kappa agonist and mu antagonist. So this is correct. Butorphanol is also kappa agonist and mu antagonist. Nalfurafine is pure kappa agonist, while buprenorphine is mu agonist and kappa antagonist. So can we say pentazocine and butorphanol are both partial kappa agonist and mu antagonist, but among them only butorphanol is given in the treatment of migraine headache, and it is the only intranasal opioid we are having which is given for migraine headache. So the answer is butorphanol. So it was a recently asked question, and this finishes our opioid. Best wishes. Thank you very much. Keep learning.